Hi, this is Dr. Bassam Rabia from Cairo, Egypt. It's a great pleasure to be giving this lecture on dental XP. Basically, this lecture is on a very significant and interesting topic that I have been lecturing for the past 7 years, and that's basically on biomechanical considerations in implant dentistry. I've been talking about biomechanics and factors affecting the success and failure rate in implant dentistry from all aspects. Today I'll be focusing basically on sinus elevation and how we can increase the rate of success of the implant restoration under loading in cases of grafted sinuses. Basically, starting my lectures, I always like to put this slide at the beginning, which we're talking about proper understanding and application of sound prosthodontic principles in the selection, placement, and restorative phase are pre-requirements for a successful implant treatment. And usually I like to put 3 levels of how to maximize the rate of success, starting from biomechanics and provisionalization and loading protocols of these implants. As I said, we'll be talking only about the biomechanical aspects regarding sinus elevation. Before going into sinus elevation and the prosthetic concepts that we have to put in mind, there are certain figures that all of us as implant dentists, whether we're restoring or placing implants, have to have it in mind. That is the normal occlusal loading. And as you can see from this slide, there are normal occlusal loading during swallowing, during of course the clinching and grinding, which is not really normal. And you can see the difference between the figures from swallowing to clinching, and in cases of course like in patients who wear full complete dentures, the amount of occlusal loads are reduced in comparison to implant supporting dentures, which become more higher, although not as cases of full dentate patients. In cases of abnormal occlusal loading, we all know that this abnormal loads increase the force magnitude, and they increase the duration of the force itself, and they change the direction of the force to a more detrimental shearing force. When I start talking about abnormal or excessive occlusal overload regarding implants, I always tend to direct my thinking towards patients who have bruxism or clinching or grinding of their teeth, and how this amount of forces can affect all our intraoral as extraoral organs like the teeth, the muscles of mastication, the temporomandibular joints, the bone of the jaws itself, the implants, and the restoration on top of the implants, or even the teeth itself. From this we can also see some signs of bruxism, which we have to analyze before putting any treatment plan for any patient who is seeking implant placement and restoration. In cases like these slides, you can see we have signs like enlarged temporalis and masseter muscles, the muscles of mastication. When you actually start palpating these muscles, you'll find there is tenderness. You ask the patient to open his or her mouth, you'll find deviation of the lower jaw on opening and limited occlusal opening, as well as you can see in the slides, the aggressive wearing of the teeth itself. Again, from clinical signs, in cases where some dentists place implants without really analyzing the occlusal scheme of these patients and whether they are clinchers or bruxers. And by the way, these slides are my slides, and by time and experience, you get to know more and more, and from the failures of your cases, you get to know why they failed. In such cases, like I placed implants, you didn't really put in mind that this patient is a clincher and really aggressive grinder. You can see to the extent that the implant abutment head itself has fractured after it's been loaded and integrated. You can see that's the remaining of the temporary bridge itself, and you can see the amount of fracture in this case. Again, we said that the signs of fracture, as you can see, this implant, another implant where it was placed in a patient which the occlusal analysis wasn't done properly, and this patient was a huge grinder. After 3 years of loading, what can you see? You can see fracture of half of the titanium implant itself. But when you come and look at this slide here, there are certain prosthetic concepts here that when we come to think about, which could lead to failure of your implant restoration. Number one, cantilevering. Number two, if you look at this is the old system, the old Bradmark system with the external hex. As we all know, most of the cases or most of the implants now in the companies, they start to produce all the internal hex apart from the external hex, because the external hex, due to the fact that it has only around 0.7 millimeter of height to 1 millimeter in comparison to the internal hexed implants, which goes down to around 2.5 millimeters. Any abutment that is placed on these external hexed are actually attached and stable by the screw and not by the hex. So any lateral detrimental forces, harmful forces, which of course you can get from the abnormal occlusal loading, as in cases of bruxers, they start to wobble this restoration, and you get either fracture of the screw, which is the weakest link attaching the abutment to the implant and the restoration itself, or you'll get some fractures beginning from fractures of your porcelain restoration. And maybe later on you get bone loss due to the lateral forces on the bone cells, and you end up with an ailing and failing implant, and a lot of times you can actually get fractures of this titanium implant. And as I was saying, because this was the early generations of implants which were commercially pure titanium and not titanium alloys, as we all know, titanium alloys and their grades have increased tremendously the strength of the implant itself. And again, coming back to the slide, we said the cantilever, the external hex, the titanium, commercially pure titanium, and you can see these are the screw retained type of restorations. Most of our restorations now are cement retained because of the screw itself. It tends to wobble, as we said, and you get fractured or a lot of screw loosening of your abutment itself. Again, some signs which we all know: increase in teeth mobility if we have natural teeth, and we can get some cervical fractions, which gives you a hint that this patient has excessive abnormal occlusal overload, and we have to really biomechanically analyze the implant itself. So in other words, the clinical and technical approaches to optimize host tissue response is basically on certain criteria. We have to select our implant from a material size, as length and diameter, the number of implants being placed, and the design factor from a macro and a micro geography of the implant itself. Placement of the implant, the surgical placement protocol, and restoration of the implant, the occlusal design and material of the implant restoration, and how we can direct our occlusal forces to become less harmful than the detrimental lateral forces itself. So really it's very important to evaluate patients with high abnormal occlusal forces that are planned for implant therapy, especially for sinus elevation. From the literature, we all know by fact that increased biting forces will result in gradual crestal bone loss and or possible mechanical failures, as I showed you in the previous slides. And from this equation that we all know from physics, that stress equals force over surface area. So really, when we're dealing with load, occlusal stresses, and our main aim is to actually reduce the amount of occlusal stresses or load, so we have to take this equation, and by increasing the surface area, we decrease the stress itself. So how can we play in the surface area, and of what? When we come to talk about implants, the number of implants, whenever possible that we can place more implants, again specifically when I'm talking in the posterior maxilla in cases of sinus grafted cases, whenever possible to place a third implant between two implants that is intended for a 3-unit bridge, it's much better, because you are, number one, increasing the surface area of this area of the load itself. Like from a book here, if we can place 2 implants and place a 3-unit bridge, which is correct, by placing the third implant to actually hold this pontic and splinting them all together, we are decreasing the amount of occlusal stresses on our implant restoration. This slide from a text I got, which is very interesting, and I'm sure everybody has seen it before, again just refreshing our minds. In the text and from the literature, we know that whenever we're placing 2 implants to restore a 3-unit bridge, and the amount of forces applied on the 3-unit bridge is 100%, whenever we change the configuration of our 3-unit bridge by placing the same 2 implants but cantilevering the pontic, this amount of force has been doubled. While if we place a third implant in the middle by increasing the surface area, that is increasing the number of implants, and they are all splinted together, the amount of forces has reduced by 1/3. If you can see in this last figure here, they are the same 3 implants, but the middle implant is an offset implant. It's out of the straight set of these implants, created what we call, and everybody knows, the tripoding configuration, and thereby this offset implant itself counteracts any rotating or tilting forces on this 3-unit bridge. Again, cases where we have extracted molars in the posterior maxilla for a while, and then you have the physiologic phenomena of pneumatization, and then you remain having only 6 to 7 millimeters of bone from the crest of the ridge to the floor of the sinus, and we need to place an implant to restore a missing first molar with a large mesiodistal diameter, which is around 11 to 13 millimeters. So what type of implant and diameter are we going to be placing that will resist the amount of forces on a first molar, which is really tremendous forces? So in cases like this, the first thing we try to do is, of course, doing a closed or internal sinus elevation by placing at least a 10 millimeter implant, elevating the sinus internally in a closed blind technique, placing the bone at the apex, as you can see, and choosing a wide diameter implant. In this case, this was a 6 millimeter diameter implant, restoring a missing first molar. In such cases, this wide diameter implant engages more surface area bone contact around the crest of the ridge and the remaining bone itself, and therefore the amount of stresses or occlusal loads that will be transmitted on the implant restoration itself will be properly dissipated around the crest of the ridge. Specifically, that again from stress and strain analysis, it is known that around 60% of the occlusal forces are transmitted around the implants at the first few millimeters at the head of the implant, which is basically, again, that's the cortical bone of the crest of the ridge itself. And the remaining percentage of forces starts to fade away around the implant itself. So you can see here, again, from the implant designs and the macro and micro geometry, we all know again that we started with the external hex. There are a few companies that still have the external hexes. Most of us are using the internal hex because of the reason I said about the internal depths of the hex itself, and if you place an abutment on top of it without even screwing it, some companies actually, by just placing it, the abutment doesn't move. And we know from before, the commercially pure smooth titanium surfaces in relation to the conditioned nowadays implant surfaces, which at the same time, whenever you're conditioning and treating your implant surface, whether it's acid etched, titanium sprayed, if it's sandblasted, any of the new technologies of treating and conditioning the surface of implant, they create internal and external surface area of bone contact around the implant itself. Again, if we look at the thread designs itself, most of the companies now are making the thread designs to the micro thread design at the first 2 to 3 millimeters of implant at the head of the implant, which again, from the stress and strain analysis, we all know that most of the concentrated forces is around these 3-4 millimeters of the head of the implant, and therefore we're increasing the surface area. Just showing a small video of one of the cases of open sinus elevation. Basically, I'm not showing this how to do the sinus elevation. I'm just showing whenever doing even sinus elevations, we put in consideration several aspects of implant prosthodontics in choosing the implant design itself, the technique of placing the implants in cases like sinus elevations, and when you don't have enough bone dimensions from the crest of the ridge to the floor of the sinus itself. Again, this is in one of the old cases I used to do. I used to use the old technique of using rotary, large round diamonds to open my window. Nowadays I'm using the piezo surgery, which is a very nice tool. And then at the end, elevating the Schneiderian membrane. You can see from this that the crest of the ridge to the floor of the sinus, we're talking around 2 to 3 millimeters. Most of the cases I would go for a 2-stage sinus elevation and then after 9 months place my implant. But in some cases, whenever I know that I have enough cortical bone to support and stabilize my implant inside the sinus, I would go straight ahead and do both techniques at the same time. By carefully elevating the Schneiderian membrane, and you can see that the bony window, which becomes the new floor of the sinus, I keep it attached, and then by drilling into the crest of the ridge, you can even start to feel the bone quality. In such cases I use osteotomes because I need to laterally condense the bone in this case, because I am intending to place an implant immediately with the sinus elevation technique itself. And in such cases, whenever you need to condense the bone, it's better to use the osteotomes rather than drilling out bone using the normal classical drills of your implant system. This is one of the systems. I've used a lot of systems. This is one of the systems that I used to use. Now I don't, but it's not a bad system. The whole idea I'm showing this is that it has micro threads, as I showed before. And these micro threads, when they come in to engage the cortical laterally condensed bone in this area, number one, they stabilize the implant inside. Number two, whenever I have forces after loading of this implant, after integration, they will be first concentrated in this area at the micro thread area at the cortical bone of the crest, which is hard bone, and therefore they will withstand any forces. And because of the microthreads, we increase the surface area contact of bone around the implant itself. And then continuing the procedure, we're placing the bone behind the implant and then in front of the implant, and then placing the membrane, the normal classical way of doing a open sinus elevation.